Okay, so hello, this is Greg Ahrens. I am a professor in the Department of Psychiatry at UC San Diego, on the west coast of the U.S., and also director of the Child and Adolescent Services Research Center. I have been involved in implementation science and implementation research for about the past 20 years with funding and support from our National Institutes of Health, the Centers for Disease Control, as well as some other non-federal funding to support my work in implementation science. And I have worked with different study designs in different settings, including here in the U.S., in public sector, behavioral health, mental health, child welfare systems, have done work in implementation studies in women's reproductive health clinics and HIV prevention in Mexico, and also involved in some projects in sub-Saharan Africa with some wonderful colleagues doing some great work in both HIV prevention and implementing evidence-based trauma care for adolescents. So enough about me, I think. But the main point I just wanted to share with you that my experience in implementation research is rather broad across different settings and different interventions and different kinds of delivery platforms. So what we're going to talk about today, and we only have a short time to go through this information, but we're going to talk broadly about study design considerations. We'll talk about observational designs, experimental research, and quasi-experimental designs, the idea of combining effectiveness research with implementation research, this idea of hybrid designs, and we'll spend a little bit of time on mixed methods, so bridging quantitative and qualitative designs. So on this slide in particular, I just want to note there's a recent rather comprehensive overview of research and evaluation designs for dissemination and implementation, so published in the Annual Review of Public Health, and led by Hendrix Brown, who is director of the Center for Prevention Implementation Methodology at Northwestern University. And Hendrix really does have a wonderful broad perspective on the field. So while we'll be touching on just a few of the issues in research design for implementation science, I really do highly recommend this publication at the Annual Review of Public Health. So, when we think about implementation studies, it really does go beyond the scope of our typical efficacy or effectiveness trials that we would be focusing on in more traditional intervention development research and intervention testing. And when I say intervention here, I'm talking about clinical interventions. But when we're talking about implementation designs, we really need to think about what's the best study to design to use when you're testing an implementation approach or an implementation strategy. And of course, this is going to depend on your particular research question and where you're working. So if you are trying to, engender physician behavior change, for example, you may use a particular strategy. If you are testing an implementation strategy to change the way a surgical treatment team functions, then you may have a different implementation question that has to do not with an individual's behavior, but how a team works together to implement best practices or evidence-based practices in surgical care, for example. If you're working with community-based organizations or non-governmental organizations in low-resource countries, you may have other questions where the larger context comes into play. So as implementation researchers and implementation scientists, we have a lot to think about that goes beyond what we have to deal with for many efficacy and effectiveness trials. Unfortunately, you have lots of options. There are many study designs that you can use in implementation research, and these can be anywhere from observational to really highly controlled experimental to quasi-experimental designs. And often these have to do with where the implementation process is. If you're coming in on, for example, a policy change that's in place and you don't have a lot of control over the conditions, then you may have an observational or quasi-experimental approach. For quasi-experimental, you may be able to use some tools that capitalize on things like propensity score matching, so you can have your target groups where implementation is taking place, but you may be able to observe what's going on in other settings and compare those using designs. But most of these designs are from the larger purview of research designs, both in medicine and psychosocial and social research. So there's a lot of literature on these, and while some of these issues may seem new to implementation science, there have been and there has been a long history of study of some of these different designs. But as we note here at the bottom, a few of these designs have really come to the fore in relation to implementation research, and we'll be talking about one example, this effectiveness implementation hybrid design, a little later on. So, when you're thinking about selecting a study design, there are lots of considerations, not the least of which is how much funding and support do we have to conduct our research. So we have the overall research question, but then we have to think about the feasibility of a design. Can we get it done? And often when we're seeking funding, we have to deal with these issues and convince reviewers about the feasibility of our designs. So we may have, our perfect design that we would like to conduct, but that may be constrained by feasibility, by things like the cost of conducting the research, the setting in which it's taking place, and the infrastructure that's available. Something as simple as having broadband connectivity in a setting if you plan to collect data in the field that relies on web resources. That may be a factor. The funding opportunities that are available often guide and direct the types of designs we may be able to use. The type of implementation strategy and the type of clinical or public health intervention also can affect the choice of study design, and also the target population. So if, as I mentioned, the target population is individual behavior change, that's one type of design. If it's team-based or multi-level, kind of a more complex context, that can affect your study design as well. The timeline also becomes important. So how long do you have to bring in your implementation approach, test your implementation strategy, and think about when you might expect to see change. Is that going to be immediate, or do you expect to see it 3 months down the road, a year down the road, 2 years down the road? And this is, I think, a great place to bring up the issue of sustainment, because I like to think that when we're thinking about implementation, we should be thinking about sustainment of those interventions. So the timeline may, the optimal timeline may be, the long run. So how do we implement in a way that we really get to that sustainability, and we can test whether these interventions are sustained as well as implemented with fidelity and implemented in the manner that we think they should be. And then, of course, another concern is the ethical issues in implementation research. And for ethics, we go beyond, I think, considering ethics in efficacy and effectiveness research, because now we're thinking also more broadly, often at the context level. So if we're looking at how people are implementing or using innovations or evidence-based interventions in a particular work context, do we have an ethical consideration at that point to consider how this affects their work life, their day-to-day life in their work context, and what that means for them personally and professionally. So it's beyond thinking about ethics for our patient populations and those who would benefit from public health innovation, and we now think more broadly about the ethics of the work we do in the workplace, in clinical health settings, in public health settings, and what that means for how we go forward. And finally, as we think about the data that we obtain, we're going to talk a little bit about mixed methods as part of this talk that I'm giving today. But there are many types of data, but there's also things like how do we house our data? Do we share our data? There's more and more demands for data sharing and making our data sets publicly available. So I think we need to be thinking about how we design our studies in a way that we have transparency, that we're able to really clearly discuss the quality of our data and how our data are housed, how our data are collected, and what that means for the work that we do. So I'm going to go right into some questions about different designs now. And so observational study designs can be really useful in looking at phenomenon or changes as they occur naturally. So in this case, there's often no ability to randomize or control how things roll out in an implementation process. Often may focus on one cohort or may be cross-sectional. I think a good example of this is where you have a policy change. So for example, here in the U.S., when the Affordable Care Act came into play, it had a lot of implications for behavioral health care, for alcohol and drug treatment, along with changes in laws that preceded ACA on parity for mental health and substance abuse services. So those are examples of large policy changes. And the National Institute on Drug Abuse funded some studies to look at the impact of policy changes such as ACA on substance abuse treatment services. And so they funded a number of studies, some that looked broadly, impact across the U.S. through large survey designs, and others that looked at more focal areas. So for example, in large urban areas, and looked at the impact on different aspects of service delivery. So when this occurs, our designs really have to bend or flex to consider, to really consider how we can get at specific issues. So for example, there might be issues of how substance abuse treatment organizations respond to and deliver services in the face of these policy changes. So it could be at the organizational level. Other studies might look at how service systems or large service sectors, so if you take a statewide service system or county-wide service systems in states that have county-operated systems, how they respond to those changes and how they use both federal and local dollars to provide services. So the observational study designs really can give us some good information about what's taking place, how it's taking place, and also potential impact on service delivery, the types of services that are delivered under mandates, and we can even build in, for example, if we have good administrative data, some assessment of what that means for engagement of services for patients and clients. So the observational study designs really can give us some good information. Another example comes from Marissa Sklar. I don't have this down in the references, but she did for her doctoral work looked at implementation of the patient-centered medical home in San Diego County, California, where the county was developing the patient-centered medical home, and adults with severe mental illness, as capacity was building, some were able to be put into the patient-centered medical home services, while many of the existing clients were in usual care services for those with severe mental illness. And she used what's called propensity score matching, which is identifying characteristics of those who went into the patient-centered medical home and identifying similar individuals or individuals with similar characteristics who were not in the patient-centered medical home, and then compare the outcomes in terms of their recovery in the process. And Marissa published that in the American Journal of Public Health, that study showing that there were benefits in recovery for those in the patient-centered medical home. So this is an example where this is, I believe, the 6th largest county in the United States, or thereabouts, made a policy decision, made a shift in services, implemented a model where we're developing evidence, and could compare the impact of that model for patients in this observational study design, but having some control. So really, we'll talk about this again when we get down to the quasi-experimental design, but these are a couple of examples of how we can look at changes in observational study designs where large policy changes or system changes are taking place, but we don't have control, we can't randomize, we can't really control what's going on. In terms of experimental study designs, they're really characterized by randomization, or we say manipulation here, but it's really control. So you have the randomized control trial, a cluster randomized control trial in which you would randomize a cluster or a clinic or a team, some other unit of analysis to a certain condition, whereas in the randomized control trial, you're typically randomizing individuals, the cluster randomized, you're randomizing units, and in the pragmatic trial, you're trying to really randomize where you want to inform decisions about practice. And I'll get a little bit more into the pragmatic trials in just a moment. And then we're going to talk a bit about the step wedge cluster randomized control trial that allows you to randomize when different units or individuals receive an implementation strategy or a clinical intervention, but then it allows you to provide that intervention strategy for everyone in the study, whereas in a typical randomized control trial, you have your intervention group or your implementation strategy group and your control group that doesn't get that strategy. So there are methods and approaches to be more inclusive in terms of providing either clinical or implementation strategy intervention. So as I mentioned, pragmatic trial, broadly defined, is an RCT, or randomized control trial's purpose is to inform decisions about practice. Where explanatory trials really measure efficacy, that's the benefit of a treatment produced under ideal conditions, not ID conditions, but ideal. Pragmatic trials focus on effectiveness, so the benefit of treatment produced in routine clinical practice. And there's been a lot of talk about this. Efficacy trials typically are done with a very highly select, highly controlled sample, with a focus on reducing kind of comorbidities. And our pragmatic and explanatory trials really focus on individuals in the community, so those who are receiving care. So as the example I gave of the propensity score matching in the patient-centered medical home, these are individuals receiving public sector services It's not a highly selected sample, but even in a pragmatic randomized controlled trial, you can randomize in a way where you're including those individuals that have co-occurring conditions that are more representative of people in usual care treatment. So what we're trying to do is maximizing both internal validity, but really focusing even more on external validity while maintaining the rigor of randomized controlled trials. So an example of this is the PRESIS type of study, Pragmatic Explanatory Continuum Indicator Summary. So the goal of PRESIS is really to help us design trials that match our intended use. And this is kind of a useful article that I've cited here at the bottom that you may want to look at by Thorpe et al. But you can also look at the article by Loudon et al. In 2015, where they provide some tools for thinking about characteristics of a trial. And so as we focus, going from the range of 1 to 5, being very explanatory to very pragmatic, thinking about these different characteristics. So the eligibility, so who's selected to participate in the trial. Are they very narrow, or do they really represent a larger kind of public health population? Thinking about recruitment, how you recruit participants into the trial, the setting or the context where the trial is being done. If you're in a highly controlled specialty clinic, that may be very different than a federally qualified health center if you're seeking to try an implementation strategy in the latter setting. It may be more representative of a larger or broader public health population. Kind of moving around the circle, thinking about the organization, what expertise and resources are needed to deliver the intervention in organizations. You have to bring in expertise as part of your implementation strategy, developing expertise. So for example, we have a project now funded by the National Institute on Drug Abuse where we have a strategy for improving leadership and organizational development around creating a context or a climate for implementation of evidence-based interventions. So we are working with expertise that exists in the organization, but thinking about the implementation strategy to help develop also appropriate expertise in supporting the implementation of evidence-based intervention in a service delivery organization. You think about flexibility or the delivery, how the intervention should be delivered, and your implementation strategy may focus on the modality of delivery. So for example, are you delivering the clinical intervention in person, face-to-face? Is it a home-based delivery? Is it clinic-based delivery? Do you have technological supports, apps, help from mobile devices or other things that are helping with delivery? The idea of flexibility and adherence. So what measures are in place to make sure participants adhere to the intervention? And when we say intervention here, it's not just the clinical or public health intervention where we think about adherence, but also adherence to implementation strategies. So in terms of design of studies, it's not just broadly fidelity, but it's fidelity to our clinical or public health intervention, and then fidelity or flexibility with our implementation strategies as well. And there's been some confusion in the field about this terminology. So it's really helpful when you're designing a study and talking about your study to be very clear when you talk about fidelity, adherence to the model, to be very clear about how you're going to assess adherence to your clinical or public health intervention, what are the measures in place for that, and how you're going to assess adherence and fidelity to your implementation strategy. So just please be very clear about that. And then in terms of follow-up, continuing to move around our circle here, thinking about in your design how closely are participants followed up? How long are you following them? Do you expect to see, for example, fidelity to your implementation strategy? So, if your implementation strategy, for example, uses leadership support to support staff in delivering an intervention, how long are you following up your leaders to see if you have behavior change in how leaders interact with the clinicians that they supervise? Right? Do we expect that to take place in 4 months, 6 months, 8 months? And do we expect that to continue on, or might it degrade, that leadership skill or behavior degrade over time? Those are all things that we should think about in terms of how we're following up or the length of the study. And then the primary outcomes, and again here, we need to think about what are our kind of clinical or public health intervention outcomes. Are we going to be looking at that? And what are our implementation outcomes? And so there's a very good article by Enola Proctor and colleagues in 2011 that lays out this difference between kind of clinical outcomes and implementation outcomes. So I encourage you all to take a look at that article. So it's Proctor, second author is Silmere, S-I-L-M-E-R-E, and others in 2011 to really get at that idea of what are implementation outcomes and how might they vary, and how do we look at that in our designs. And then for our primary analyses, what are our real targeted outcomes that we want to look at in terms of our implementation strategy? So what do we expect to change? If it's individual clinician behavior change, we can, how do we measure that individual behavior change? Is it through self-report? Is it through observation? What are the metrics that we're going to look at in our primary analyses? Or if it's at the team level or organization level, we need to think about complex analyses that take into account the nested data structure, which becomes very critical in implementation research. Thinking about how providers may be nested or working within a clinic, and how you may have common variants related to that clustering of how people are working in organizations or in specific clinics. So, I think the more we can really get at these different aspects in the PRECIS approach and get at these more contextual issues and thinking about both the implementation strategy as well as what is being implemented, then our trials will be more pragmatic. And I think the other code word for this is that we would have good external validity as well as good internal validity. So really, for implementation science, this idea of external validity becomes really critical in thinking about the relevance and potential impact of what we're testing in implementation science. I mentioned earlier the step wedge cluster randomized control trial. And so what we see here is that we have participants or clusters up on the left and time going down on the bottom axis, the x-axis. And the idea is that, so say you had 5 clinics that were going to be involved in the study. They all wanted to get the clinical innovation, and you were testing an implementation strategy in each. What you might do is have a period, if you look at the time period 1 on the x-axis on the left, where you're just doing measurement to get a baseline for the clinic operations. So again, I'll use the example of a leadership intervention. So you measure leadership, you measure climate for implementation of a new innovation in all 5 of those clusters, and then at time period 2, you do your implementation strategy to implement your new innovation with clinic 1 or cluster 1, and you're measuring all of the clusters, all of the clinics again. At time 3, clinic 2 gets the implementation strategy to implement the innovation, and all of the other 3, 4, and 5 serve as controls for clinic 2 and 3. And at time 4, then now you have 3 clinics involved. Time 5, you have your 4 clinics, and finally at time 6, you have all of your clinics who've received the implementation strategy and the clinical or public health innovation or intervention as well. And so one of the characteristics of this is that you're collecting data from all of your sites over the course of the whole study. So the real plus of a step wedge design is that all of the units receive the intervention and receive the implementation strategy. The downside is that you are then doing measurement of all of these clinics over time. So there's a little more burden, sometimes a lot more burden, in terms of the data that you're collecting. And so that can be kind of a critical decision point in busy clinics or busy organizations where you're asking them to participate in a research study, and hopefully they'll be getting some benefit in terms of the implementation strategy and in terms of any clinical or public health innovation. But then there's that balance of kind of burden. Do our staff have the time to participate in measurement while we're really still providing clinical or health services? So it does become an issue in balancing that, and there may be an increased cost in doing a step wedge design. So, in that kind of laundry list on selecting a study design on, I believe it was slide number 4, the cost and practicality have an impact on how you select a particular design. So let's talk a little bit about some quasi-experimental study designs, and I already alluded to that a little bit in terms of the propensity score matching design, which was observational, but puts some control. I think we'd consider that both observational and quasi-experimental. But some of the common quasi-experimental designs that you'll hear about and may be interested in using are regression discontinuity design, where individuals or groups are assigned to an intervention or control based on a priori score or metric. So we evaluate, then assign, and then look at change over time. A non-equivalent control group design, where one group receives an intervention and one group is control, but they're not necessarily predicated, so they're not randomized. And again, I just want to say one thing about randomization is that randomization is based on statistically based on the law of large numbers. So randomization works well when we have a large number of units, and whether that's an individual person or an organization or a service system or a state or a country. Randomization works well when we have large numbers. Often in implementation science, we're interested in unit performance or unit change, and a unit could be an organization, it could be a team. So when we go to that kind of design, we typically have fewer units than we would have individuals. So we need to think carefully about how well a randomization will work versus a quasi-experimental design. So for example, you may want to match groups and then randomize to conditions, which will help overcome some of the issues with a pure randomized controlled trial. So non-equivalent control group design, it's a bit of a tough design because you can compare your groups at baseline, but you can't control for unmeasured differences. So in this design, it's important to try to identify key factors that you believe will be important across groups so that you can control for those in your statistical analyses. In terms of an interrupted time series, this is a nice design because you have multiple assessments prior to and following the introduction of an intervention, and so, or even an implementation strategy, so you can get more accurate assessment of outcomes or behavior than single pre-post assessments. And, you know, an example is, you know, where you're measuring over time, outcome on the left axis, time on the x-axis. So you're looking at the slope or change over time prior to the intervention. You have a set time when your implementation strategy or your clinical innovation is introduced, and you can determine whether there's a change in slope over time on your outcome of interest. So this could be an implementation outcome. So if we expect leadership, for example, to lead to change in the team climate for use of an evidence-based practice, we would expect to see, you know, change after the leadership development training occurred and leaders were changing their behavior. We would expect to see a related change in climate for implementation if they're leading their teams well. So I'm going to jump over to the idea of adaptive design. And in adaptive design, this is a kind of really, I think, novel and interesting development that Hendricks Brown, again, had written about back in 2009. The planned modification of characteristics of a trial based on information from data already accumulated. So as data are collected, they're used to make anticipated choices about pre-specified alternatives. And Hendricks talked about three types of adaptation or adaptive designs relating to specific elements of study design of an ongoing trial, relating to the design of an upcoming or next planned trial, or related to the intervention or its delivery. And we see this in this idea of what's called a SMART trial, a sequential, multiple assignment, randomized trial, big fancy name, but can be really elegant in terms of, you know, being adaptive designs and adaptive interventions for implementation research. And so there are a number of kind of premises for these designs, that there may be heterogeneity of practices and characteristics of providers. Not all barriers or facilitators to implementation or use of practices are observable, that we want to deliver implementation strategies where needed, that we need to react to non-responsive or limited uptake, and that we can have sequential randomization as we learn about whether individuals or organization units are responding or not responding. We can reduce implementation burden using more specifically what is necessary, and then it helps us kind of understand or sift through available implementation strategies. We could be more site-specific and hopefully improve sustainment or sustainability. So I think a really nice and elegant example of a SMART trial is the Adaptive Implementation of Effective Programs trial, ADEPT, led by Amy Kilborn. And the primary aim for this is to look at sites not initially responding to replication to implement collaborative care, looking at sites receiving external and internal facilitator versus external facilitator alone. So there are a number of implementation frameworks that talk about the role of facilitation and whether that external or internal facilitation alone or combined may improve uptake of evidence-based interventions, in this case collaborative care visits, and whether these might be related to patient outcomes. And so for this study, the secondary aims focused on looking at continuing the two different approaches to facilitation and looking at continuing the facilitation for a longer period of time. So in the ADEPT trial, there's the study starter run-in phase where all sites are offered the facilitation to implement evidence-based practice, and then patients start by month 3, so at 80 sites. And then some of those sites may be, quote, non-responders, so, where they're not responding to the facilitation. And so what you see as we move over to the right, that R in the blue circle randomizes non-responders to add external facilitation or add internal and external facilitation. And then as you go forward, within those different facilitation conditions, there may be responders and non-responders. And so again, the study is adaptive in randomizing again to just assessment, continuing the types of facilitations, or adding additional facilitation. So as you go forward, this is a really nice example of how you can learn something about how sites are responding to different types of facilitation, and then learn more about how adding different components to the implementation strategy. And here the implementation strategy is the different types of facilitation. How you add to that and learn characteristics of these clinics that may be related to whether they respond or not, and then testing whether kind of adding components has an effect in terms of improving the implementation of care. So just a really nice, elegant design, I think. So next I want to talk about effectiveness implementation hybrid design. And this came about, I think, because, and I've talked to the authors of this paper about this a little bit, implementation researchers were starting to do some of this, but there wasn't a name for it. This idea of looking at clinical or public health intervention effectiveness at the same time that we're looking at implementation issues or implementation strategies. So the focus, there's a dual focus, a priori, on assessing both intervention effectiveness and implementation strategy. There's 3 types, but the overall goal is to accelerate the transition from effectiveness to implementation trials. So we want to kind of shorten the time that we go from testing clinical and public health interventions to getting those in the field through the use of implementation strategies. And these really are unique to implementation research. So in effectiveness trials, we're really testing the clinical intervention. It could be behavioral psychosocial intervention. It could be a drug or pharmacological intervention. It could be a device. It could be use of different approach to surgical care. The unit of randomization is generally the individual or the patient. Unit of analysis is usually the patient, and outcomes are usually health outcomes. In an implementation trial, we're focusing on the implementation strategy. It could be facilitation. It could be training models or training approaches. It could be the use of clinical reminders. It could be different type of supervision. The unit of randomization is often at the provider level, not the patient or the clinic or even a service system. The unit of analysis then is also provider, clinic, or system, and it focuses on adoption and appropriate use of the intervention, but it's the implementation outcomes. So it could be the fidelity with which the intervention is being used. But as well, we may want to focus on and look at fidelity of the implementation strategy and issues that affect the implementation strategy as well. So the 3 types, kind of going from focus on clinical effectiveness on the left to implementation effectiveness, so the implementation strategy on the right, is the hybrid type 1, where the real focus is on the clinical intervention, and we're just observing or gathering information on implementation issues. So we may conduct some qualitative work and look at factors that are believed to affect implementation, or look at organizational context. for a hybrid type 2, we're going to be testing both a clinical intervention and an implementation intervention, so that we're not just observing the implementation strategy. Now we're testing an implementation strategy. So if we have a leadership approach, we're maybe testing one group that gets the leadership development and another group that doesn't. In a hybrid type 3, we're really looking at a focus on the implementation strategy, and we may be observing just the client level or patient level outcomes, maybe through administrative database. So we're really moving from observation of implementation to equal testing of clinical intervention and implementation strategy, and moving more to a real focus in the hybrid type 3 on testing the implementation strategy with less focus on the clinical outcomes. So that's really the 3 hybrid types. And I have some more slides that describe this in the intervention for you, but I'm going to move on now, hybrid type 1, type 2, type 3, so you'll have those slides available, and basically they just give examples of what I just talked about. And so I want to talk briefly also about mixed method designs, and many of my studies incorporate mixed methods, so I really like this particular slide with a focus on a couple driving over a bridge, and she says, "Who would have thought that a structure of steel could be so beautiful, strong, and delicate at the same time?" With the qualitative perspective and the quantitative perspective, it shortens my commute to work by 12.7 miles. So really different approaches to the same phenomenon, but we can learn a lot by really bringing those designs together. So mixed method designs have to do with collection and integration of qualitative and quantitative data, and mixed methods are a really good approach for understanding processes, context, and complexity, and we can embed these two together using qualitative methods, including interviews, focus groups, observation, review of documents, such as policy documents, for example, with quantitative data, including surveys, including outcome data, including the data about the nature of the context. And I am trying to advance this slide, so just hold on a minute. Okay, so my slides are not advancing, so okay. So I got my slides to work, so here we go. So in terms of mixed method designs, there's a number of different typologies out there. Dr. Larry Palinkas, who's at the University of Southern California, has done some nice work in kind of talking about mixed methods designs and implementation research. And so 3 kind of larger approaches are thinking about kind of concurrent mixed methods at the top here, where you're collecting your qualitative data and your quantitative data concurrently at the same time as you go, and then bringing your results together. And one of the benefits of this kind of parallel concurrent approach is that your data are happening and you're collecting those data around phenomena at the same point in time, so people don't have to like remember back or things like that, do retrospective kind of reconstruction, that you're really collecting those at the same time. But sometimes, you may want to do a sequential design where you're collecting qualitative data and then quantitative data. And I'll just say here, when you see like the uppercase letters versus lowercase, that just indicates what data are primary in that design. So in concurrent, both qual and quant are primary. in the sequential where qual comes first and then quant, you may be more interested in your qualitative, and it leads to quantitative data that's going to lead to your results. Where you see sequential design with qualitative and then quant often is in measure development. So you have kind of an inductive approach. Sometimes you may use your quantitative data primary and then bring in your qualitative data to learn more about the phenomenon that you're measuring quantitatively. So you can use your quantitative data, for example, for purposes of sampling, so that you're really using those data in a way that informs how you're going to ask the qualitative questions. And then you can have embedded sequential where these really kind of work together as you go forward. Some other ways to think about these are, I talked about the embedded design where you're collecting qualitative and quantitative, a broader and more comprehensive understanding of a complex context and process. So you're conducting one within the other type of study. And that's often related to a sequential design. So an embedded example is, say you're conducting a randomized trial to test different strategies for training community health workers to deliver smoking cessation. So you might use that embedded design to really get at the issues that community health workers are facing in delivering those implementation strategies as you go forward. You need to be thinking about what type of quantitative data you would collect over time, how often, from whom, and then the nature of the qualitative data. Would you want to have observational data of the training sessions, of how workers are delivering the smoking cessation intervention? Would those types of observational approaches be best, or would you want to ask community health workers about their experiences in the training, with the training, and how well that led to their being able to deliver the smoking cessation? So there are a number of different approaches that you can use in thinking about the quantitative and the qualitative. In an explanatory model, you may move from the quantitative to the qualitative, so help explain or build on initial quantitative results. And so you can use quantitative participant characteristics, as I mentioned, to use purposive sampling, so you're identifying those who can tell you the most, maybe those who've done really well with the implementation strategy or those who've done poorly, and get those very diametric perspectives. And that's a sequential design. So you may, an example, administer a survey to health practitioners to understand their attitudes about the HPV vaccine, and responses can range across the spectrum from positive to negative. And so the explanatory design can help you, so you can think about how you would use the quantitative data. What specific questions in your quantitative data would inform your sampling approach, and what types or what approaches to qualitative data collection you would want to collect, and from whom. And if you wanted to do that just once or at different places in the process. So for example, as health practitioners gained experience with delivery of HPV and engagement in patients, would their perspective change? Would you expect their perspective to change? And if you did, that might lead you to a more prospective design, where you would maybe collect some data early on and collect data later on to see if there had been attitudinal change, and what was related to the attitudinal change. And then for exploratory, your quantitative data can help explain or build on initial qualitative results. And this can have to do with something that I'm going to talk about in a minute around expansion of results. So your quantitative data can help explain or build on initial results. And the exploration may be needed because we're just learning about the phenomenon, or thinking about the context and learning to understand the context in which we're implementing a new practice. So it may be beginning with the qualitative and moving to the quantitative in a more sequential fashion. So let's take the example of HPV, where self-sampling is available in the community, but very few women are use the HPV vaccine. You want to understand barriers towards correct use of self-sampling and develop an instrument to measure that. So you might use the exploratory design. You would need to think about what type of qualitative data, from whom you want to collect the data, and then how you would use those to identify either domains or constructs that you would develop quantitative measures from that. So you would use that qualitative data to help identify the domains or important domains that you would use to develop quantitative assessments and specific items to develop measures. So another way to think about this is, the design type, and in a way we're already talking about, convergence of methods, complementarity, exploratory and developmental, and expansion. So in convergence approaches, or the function of mixed methods, we're thinking about how our quantitative and qualitative data come together regarding the same phenomenon. And we may want to collect our data concurrently and use that for interpretation. And so qualitative and quantitative may be very equal in that approach. For complementarity, we may want to understand a phenomenon more completely. So we may have a sequential data collection approach and use analysis and interpretation in terms of our mixing of the methods and moving from quantitative to qualitative. We just talked about kind of more exploratory developmental, so I'll skip to expansion, and that's more of an explanatory model where we want to assess different phenomena using different methods. We may use an embedded sequential approach, and our analysis and interpretation would help us go a little deeper into our findings from one approach. So our quantitative may inform our qualitative, or our qualitative may inform our quantitative. It really can vary as we're thinking about that. And so I just want to give one example of a study that uses those design types, and I'm going to focus on convergence and expansion here. So this was a mixed method study of a statewide implementation of one evidence-based practice. In this case, it's called Safe Care, which is a child neglect intervention. And in the state, there were 6 regions, and the state agreed to allow regions to be assigned to either receiving the evidence-based intervention or services as usual. And then teams within the region were randomized to fidelity monitoring, which was done by either having coaching or no coaching. And so this study combines exploratory and confirmatory approaches, and it's longitudinal at the team level. So the data were collected from team members, both through quantitatively through web surveys about organizational context, and through focus groups and surveys with service providers and system leaders as well. And so we're examining reciprocal effects of implementation of the evidence-based practice on the service system and organizations, as well as how characteristics of the organizations can in fact impact implementation. And for this particular project, we focused on the impact of implementation on staff retention in care, because turnover of personnel and implementation of evidence-based interventions can be a critical concern. So what we found quantitatively was that where the evidence-based practice was implemented with ongoing monitoring and coaching, we had significantly better staff retention. So you can see that in the survival analysis estimates on the left, and in the right you can look at the annualized turnover by condition. So Safe Care, yes, and having the ongoing consultation and coaching, yes, the turnover rate was annualized, it was 14.9%. compared to more than double that in all the other conditions in this experimentally controlled study. But when we looked at the quantitative and qualitative, it tells us a little bit more about the study. So we had specific questions, and when you're thinking about mixed methods, you need to be thinking about how you're going to present and mix your mixed methods. And this is one area where grant proposals can really fail. If folks say, if you say you're using mixed methods, but you don't talk about how you're mixing them, how your quantitative informs your qualitative or your qualitative informs your quantitative, reviewers will really jump on that. So in this slide, you can see that we have a question, and the question is the same for our quantitative and qualitative data. Does safe care implementation increase the risk of turnover? Quantitatively, the answer is no. Providers in the safe care monitor condition had a greater likelihood of staying with their agencies, and qualitatively, we found in the data that many providers reported satisfaction with the structure provided by the evidence-based practice, and none of the providers reported leaving primarily because of their involvement in the effectiveness trial of the evidence-based practice. The other question was, does fidelity monitoring or coaching increase the risk of turnover? Quantitatively, the answer also is no. The home-based providers in the evidence-based practice, safe care, and monitored condition had a greater likelihood of staying with their agencies, and many of the providers qualitatively reported satisfaction with the support they received from monitors or their coaches. So they're answering these questions. And then we had additional hypotheses about perceived job autonomy and the relationship of job autonomy to turnover was supported, but it's not a function of the evidence-based practice. So in the interest of time, I'm just going to move on to this idea of expansion. So as we mentioned previously, expansion tells you more or takes you more in depth about a phenomenon. So here, the question quantitatively was, does safe care implementation and or monitoring lead to increased turnover? And the answer is no. The home-based providers in the safe care condition had a greater likelihood of staying with their agencies. Qualitatively, though, we can say, why are they more likely to stay? And what our qualitative data told us was that providers liked the structure, especially early career providers, that they liked the structure that safe care provides the services. They felt that the support they received from their coaches or monitors, they viewed that as free supervision. It was seen as supportive. And so the providers also supported one another in applying the evidence-based practice, and they developed a professional identity around the delivery of the model, whereas services as usual providers reported decline in morale due to factors unrelated to the practice. So, for example, conflicts with supervisors, changes in leaderships, and fewer opportunities for learning, for having a team identity. So in the case of expansion, being able to place your quantitative and qualitative findings side by side can really help illustrate how you're using and how you're mixing your mixed methods. So we've covered a lot in this talk, and there's a lot to learn about designs. I'll refer you back to the Hendricks-Brown article in Annual Review of Public Health for a really nice overview of many designs with a lot more detail than I can present here. But the best study design is to use the ones that can answer your research questions, of course. But your selection of a study design, issues of feasibility, cost, resources, timing, the team you're putting together, and being able to answer your implementation research questions. And this is where those hybrid designs come in as well, thinking about that balance of focus on implementation versus effectiveness. But on the plus side, there really are a variety of designs to choose from and consider. So with your research team, really sit down and say, here are our questions. We're focusing this, this much on implementation, this much on effectiveness. What are our designs? Do we have the ability to randomize? Do we randomize at the cluster level, at the individual level? Do we want to bring in qualitative methods? If so, what's the best way to do that? How are we going to use the two methods together most effectively so that we can really learn how to bring evidence-based interventions to scale to promote better clinical outcomes and better population and public health impact. So we'll leave you with that. Thank you for staying with me for this talk, and I have my contact information. If there are questions, you can direct them to me or to your TIDIRC mentors and other folks that are working with you at TIDIRC. Thanks very much.